If we look at this big picture, Keith, your sort of philosophy for combination treatment, I mean, dropping the intraocular pressures again, if you get somebody who's presenting with maybe already quite significant visual field loss, you're going to drop the pressure, and if that needs a trabeculectomy or tube or whatever. But what's your vision of, say, 10, 20 years time? What's treatment going to look like for these patients with, in your words, proper glaucoma? Not a little touch of ocular hypertension, but people with potentially blinding disease.
So I think there are two issues here. I mean, one is that lowering pressure is great, but it doesn't solve the problem for a bunch of patients. So you need other stuff. And the other thing is we lump a whole bunch of different conditions together, and we call them primary open-angle glaucoma. And there are a bunch of different diseases in there. I mean, it's a nonsense compared to how refined we are in terms of the phenotyping of other types of disease. You look at breast cancer, there are a whole different range of molecularly phenotype types of breast cancer. They all have different treatments. We don't expect the same treatment to work. We did when we were training, John, and they would get chemotherapy or radiotherapy because they had breast cancer, and we would stage
Yeah.
it, and but now everything is molecularly phenotyped, and within glaucoma, some of our glaucoma patients, we're talking about a connective tissue disorder. They have stretchy eyes, they're high myopes, they've got
Yeah.
connective tissue is the main problem. For others, it's a mitochondrial thing. It runs in their family. They've got, some of them have detected mitochondrial mutations. And for others, it's a vascular disease. They come in with freezing cold hands. They're a marathon runner, thin, and
Yeah.
they got migraine. It's clearly, that
Different.
mechanism
Yeah.
is related. It's different again. And yet we lump all these things together. We expect the same treatments to work. Why should even the same drops work? We don't even know that the millimeter for millimeter treatment with different medications is equally effective. There's a story that in certain circumstances, beta blockers may make things worse for some of these patients. So I think being able to tailor treatment to patients, and that's going to come